Welcome to CME on ReachMD. This activity, titled Sjögren's Mythbusters, Can You Detect Fact from Fiction on Emerging Therapies?, is provided by Clinical Care Options LLC, doing business as Desera Clinical Education in partnership with Smart Patients. Prior to the beginning of the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
We're learning more and more about what causes Sjögren's. One thing that seems clear is the salivary gland epithelium, which you see in the bottom left-hand corner there. Those two healthy-looking cells, and then you look to the right, there's a lot of kind of cells that look haggard and unhappy. We know the salivary gland epithelial cells are not the victim here, but also part of the whole crime scene. They're contributing to the problems as well as being part of what's being damaged. It's thought that there's a microbial trigger, as you can see on the left side there. And then as you go left to right, you can see there's interferon, type 1 interferon production from the epithelial cells. There's also release of autoantigens and nucleic acids. There's also upregulation of MHC, which we wouldn't normally see in this type of cell, but it's upregulated as these cells are kind of more immunologically active. All of this contributes to autoreactivity with B and T cells, as you see up here. B cells get activated, releasing autoantibodies. So we have autoantibodies like SSA. We have B cells, plasma cells, T cells invading the epithelium, causing inflammation. That's what we'll see in lip biopsy samples. We have damage and release of different materials, which together can form immune complexes between the antibodies and antigens. And dendritic cells can then release interferon, kind of sensing these immune complexes, which kind of continues the whole cascade around and around and around. So myth number one, Sjögren's disease is just dryness. A lot of patients are told this by their providers. They get very upset by this because we know Sjögren's is so much more than dryness. Of course, Sjögren's is an autoimmune disorder. It affects the exocrine glands, but it can affect so much more. The main symptoms are dry mouth and dry eye, and common symptoms also include fatigue, aches and pains, amongst others. And we know that Sjögren's can occur alone, but it can also be seen with other autoimmune conditions. About a third of lupus patients may have Sjögren's. Maybe about a tenth of rheumatoid arthritis patients have Sjögren's. You can see it in scleroderma, primary biliary cholangitis, and others. And Sjögren's is so much more than dryness. As you can see here with this next slide, so many different organ systems can be involved. You can have musculoskeletal system. About 2/3 of patients can have joint and muscle involvement. Then you see the skin. People can have Raynaud's, various types of vasculitis or other rashes. Next, you can see neurologic. About 2/3 of patients with Sjögren's have symptoms suggesting neuropathy. And many patients have numbness, tingling, other symptoms. Up to 50% of patients, according to some studies, have symptoms suggestive of autonomic neuropathy. I certainly believe that I see that in a large percentage of my patients. And then next you see renal. Patients with Sjögren's can have type 1 renal tubular acidosis. So you can look for patients with hypokalemia or low bicarbonate level. Can also have glomerulonephritis in some cases. Hematologic, a lot of patients with Sjögren's have cytopenias or other abnormalities in the blood, like with complement and others. Pulmonary airways disease is seen in about half of patients with Sjögren's. ILD seen in about 20% of patients with Sjögren's. Cysts are commonly seen on CAT scan of patients with Sjögren's. The GI system is very commonly affected in Sjögren's. Autoimmune stuff in the GI tract includes autoimmune hepatitis in a small percentage, primary biliary cholangitis in about 5% or less. You can also see dysautonomia and problems with motility as pretty widespread in my Sjögren's patients. Cardiovascularly, people with Sjögren's are at increased risk of coronary artery disease, and more recent studies show their increased risk for arrhythmias and other cardiac issues. I think I used to think that Sjögren's pretty much spared the heart, but now it seems pretty clear it does affect the heart as well. So, Sjogren's is not just dryness, really affects every organ system. And it's also not just some kind of mild syndrome. A lot of people think of it as something like, oh, fibromyalgia syndrome, Sjogren's syndrome, no big deal. Has really profound effects on patients. As you can see here, the mental health, 80% of patients say their disease causes significant emotional burden. For home life, 76% report stopping or cutting back on housework. Cognition, 80% report experiencing brain fog as a symptom. I see this all day long. Financial health, about 2/3 say their disease imposes significant financial burden. Work life, 64% said they had to make work changes at work. And then 33% report that their disease affects their ability to enjoy food. Really not fun. And patients with Sjogren's are at increased risk of developing lymphoma. About 1 in 10 to 1 in 20 patients with Sjogren's eventually develop lymphoma. This is a 20-fold increased risk compared to the general population. This slide shows a predictive score for non-Hodgkin's lymphoma, which was published about 10 years ago. The takeaway here is if you have 3 or more of the risk factors you see in the bottom left, the risk for non-Hodgkin's lymphoma goes up significantly between having a positive SSA, positive rheumatoid factor, salivary gland enlargement, lymphadenopathy, Raynaud's, monoclonal gammopathy, and C4 hypocomplementemia. Risk factors for mortality, mainly the lymphoma, again, 5 to 10% lifetime risk, and ILD. ILD affects about 20% of patients with Sjogren's. Almost 60% of deaths are attributable to comorbidities. If you ask patients, they know what's going on here, and they feel sometimes providers are in the dark. If we look at the key takeaways here on the right in red, patients frequently described long diagnostic journeys accompanied by uncertainty, dismissal of symptoms, emotional distress. Patients reported difficulty with having their non-dryness related symptoms recognized and validated. I think a lot of times people feel like their symptoms are not taken seriously. Patients expressed variable levels of trust that depended on whether their healthcare providers acknowledged their uncertainty and invited questions about care options. All right. Myth number 3 is that Sjogren's disease only affects middle-aged women. We know Sjogren's affects 1 to 4 million people in the United States. Women are at least 9 times more likely than men to have Sjogren's. So I do have men with Sjogren's in my panel, but far more women. Men may be more likely to have higher disease activity, higher constitutional symptoms, lymphadenopathy, pulmonary, and liver involvement. And so ILD is something we really need to look for in the men with Sjogren's. Average age at diagnosis for Sjogren's is mainly people in their 50s. It's often misdiagnosed and underdiagnosed. I see this all day long. In part, this is because it requires multiple specialists to diagnose. I mean, I don't know about you, but I can't use a slit lamp, so I can't do an ocular staining score. I can do a Schirmer test, but ocular staining score is actually more sensitive. Schirmer can be totally normal. Ocular staining score can be very abnormal, indicating dryness. And also, I don't do lip biopsies. There are some rheumatologists who do this here in the United States, but I think they're few and far between. Most of us have to rely on an ENT specialist or some other oral specialist to obtain a minor salivary gland biopsy. The average time to diagnosis is about 3 years. And men and children may experience longer delays due to misconceptions and missed symptoms. There are atypical presentations and some heterogeneity in racial minority populations. People with African ancestry demonstrate more hypergammaglobulinemia, increased sed rate, and parotid enlargement. And Native Americans show lower rates of abnormal tear and saliva production and greater disease activity. There's comorbid conditions, some of which are autoimmune. In the survey of over 3,000 patients by a Harris poll that was shepherded by the Sjögren's Foundation, more than 80% had at least one ocular, oral, nervous system related comorbidity. 70% had more than one other comorbid autoimmune condition. They didn't talk to us when they put this together. Most of us don't consider fibromyalgia an autoimmune condition per se, but it is a comorbid condition. It is common in our Sjögren's patients, as well as rheumatoid, Hashimoto's, and others. When I see people with fibromyalgia with a positive rheumatoid factor or fibromyalgia with a positive ANA, I think Sjögren's. And certainly someone has Hashimoto's or family history of autoimmune disease, I'm concerned for Sjögren's. All right, more questions. Post-test 1. A 52-year-old woman with Sjögren's disease reports persistent fatigue, widespread pain, difficulty concentrating despite stable sicca symptoms. She's concerned that her disease is worsening. Which statement best reflects the burden the patient is experiencing? Is it A, Sjögren's disease is primarily limited to the salivary and lacrimal gland dysfunction? B, impacts on daily living and cognitive symptoms may reflect systemic Sjögren's? C, these symptoms indicate a coexisting autoimmune condition? Or D, extraglandular manifestations occur infrequently and usually late in the disease course?
And polling is open. Please vote. We'll give a few more seconds for incoming replies. Thank you. And we'll close that poll and share the results.
Okay, very good. I think you guys know the answer, so we're going to move on here. Impacts on daily living, cognitive symptoms may reflect systemic Sjögren's. And the rationale here is fatigue, chronic pain, cognitive impairment are common. Impactful features of Sjögren's disease. Fatigue is really the #1 symptom that Sjögren's patients have that affects their quality of life. These symptoms reflect systemic immune dysregulation, significantly affect quality of life. Acknowledging this burden is important for patients, patient education and validation. Totally true. All right, screening and diagnosis. Early diagnosis of Sjögren's is critical for symptom management and prevention of oral complications lymphoma. Wide spectrum of clinical presentations and high prevalence of atypical symptoms make the diagnosis challenging. This is so true. Sjögren's can present in so many different ways. If you see somebody with rheumatoid arthritis and they have like fibromyalgia, strange numbness and tingling that doesn't make any sense, I think of Sjögren's. You see someone with lupus who has some mild dryness, but they have maybe some gland swelling, definitely think of Sjögren's. People with, if you get a consult for somebody with strange neuropathy symptoms, the neurologist found a positive, rheumatoid factor ANA, I think of Sjögren's even without the SSA. Healthcare providers may not inquire about the dryness as a symptom, and I think this is what throws a lot of people off. We know in the literature that subjective dryness and objective findings of dryness often do not correlate. So I've had patients tell me that they have no dryness at all, and then I do a Schirmer test and they literally didn't make any tears. There's no wetness of the paper at all. If I stick this Schirmer paper in your eye, if you have normal glands, that will get wet very quickly. 5 minutes in this person's eye and there was no moisture at all, and they didn't complain of dry eye at all. So the symptoms and the objective measures often don't go together, which is why it's really important to do objective testing on patients, even if they're not complaining, if you suspect the diagnosis. And patients may not know to mention dryness as a concern. They might not think it's relevant. Salivary gland biopsy is often important for diagnosis. It's not always needed in clinical practice, but often needed for a definitive diagnosis. So if you ask me, when do you order, when do you do a salivary gland biopsy? My simple answer is if my suspicions for Sjögren's is high enough and the SSA is negative. That's kind of like my basic answer. There's a lot more nuance to it, but I imagine we'll talk more about this later if people have more questions. All right. ACR-EULAR classification criteria for Sjögren's disease. Of course, this is classification criteria. It's meant for trials, but in the absence of diagnostic criteria, this is often used as at least guidepost to help people with diagnosis. I think it's useful for that purpose. I may not use it strictly this way, but it is helpful. And what you see here is to be classified as a Sjögren's patient, you need a score of at least 4. So the bottom 3 criteria are all about dryness. And I explained to patients, having dryness alone does not mean you have Sjögren's. There's so many reasons why you might have dry eye or dry mouth. Doesn't mean that it's an autoimmune disease. We need evidence of autoimmunity. In terms of classification criteria, the strict evidence of autoimmunity is a positive SSA or a lip biopsy with a focus score of 1 or more. And so if you have one of those 2 pieces at the top and one of the pieces at the bottom, then you meet classification for Sjögren's, and the diagnosis, I think, is pretty sound. How do we tell how active someone's Sjögren's is or how bad their Sjögren's is? This is very difficult to do, but for studies, we look at the Sjögren's syndrome patient reported index, which basically reports symptoms. How bad are your symptoms? And this looks at the main symptoms of dryness, joint pain, joint muscle pain, and fatigue. Essentially, patients are asked on a scale of 1 to 10 for each of those, and then you come up with an average. So, if you have 5 dryness, 10 joint pain, 0 fatigue, the score overall will be 5. And so greater than 5, as you can see here for the ESPRI, is high disease activity, high symptom activity. Less than 5 is low symptoms. Less than 3 is like minimal. And then a change of 1 is considered statistically significant. What you want to see in studies, which we'll look at later, is that the ESPRI change at least by 1 point, which would indicate that the subjects or the participants in the study, their symptoms had some significant improvement. And then here we have the ESDI, which is the Sjögren's syndrome disease activity index. And so what this is trying to measure is systemic activity. And the reason why there's 2 different measurements is because we know patients may have lots of symptoms, but may not have a lot of organ or systemic involvement. And so we're kind of measuring both of these things concurrently. This is measuring the systemic involvement. And as you can see, there's a bunch of different domains here. Constitutional, that's basically asking people, have you lost weight? Do you have night sweats? Any unexplained fevers? Lymphadenopathy, which we'll find like on exam or imaging. Glandular abnormalities like parotid swelling. Articular involvement like synovitis or significant arthralgias with significant stiffness. Cutaneous, it's hard to find this, but these are significant rashes like purpura or subacute cutaneous lupus. Pulmonary, so do you have any PFT findings or imaging findings consistent with like ILD? Renal, do you have any findings consistent with tubular interstitial nephritis, etc.? Muscular, do you have elevated CK or EMG that's positive? Peripheral nervous system, do you have EMG findings consistent with neuropathy and others? Central nervous system, which is rare to score. That's like for people who have optic neuritis or transverse myelitis, something of that nature. Hematologic is common for my patients to score here. People who have anemia of chronic disease, for instance, or mild thrombocytopenia. And then biological, this is people who have a biological domain is essentially looking at like low complement scores, hypergammaglobulinemia, cryoglobulins. So if we look here at the bottom, an ESDI score of less than 5 is considered low disease activity. We have maybe something like 2,000 plus patients in our cohort here at Penn. Our average ESDI score is like 2 or something like that. So low disease activity is pretty much the norm. If you look at the average ESPRI, I don't know what it is, but I imagine it's above 5. And patients have lots of symptoms, but they may not have systemic involvement. It's all that significant. A score between 5 and 13 is moderate, and a score above 13, 14 is high disease activity. And what's important is a change of at least 3 points has minimal response to treatment from a clinical standpoint. So later when we look at some of these trials, you want to keep this in mind. Do they have an improvement in the ESDI of at least 3 points? That would be considered clinically significant improvement. And that's quite a bit, because if your score is like 6, then you have moderate disease activity, it improves by 3. Now you're down at low disease activity. That's pretty good. Next, we see systemic domains outside the ESDI domains. This is basically showing you that patients with Sjögren's have a whole lot potentially going on, and not everything is measured in the ESDI. There's a lot of patients online who are really mad about this. I think some of this is, I'm not quite sure exactly how accurate this is. It depends on how you measure it. For instance, like in the bottom right here, you see dysautonomia. I mean, dysautonomia is hard to measure. According to some studies, patients with Sjögren's, if you ask them a dysautonomia questionnaire, like a compass with like 40 questions, about half of patients with Sjögren's kind of qualify for dysautonomia, at least based on the subjective questions. I think dysautonomia is a lot more common in Sjögren's than this. And that's why a lot of patients get mad at me, because I tell them that according to their ESSDAI, their disease activity is low, but they feel very terrible and they're dizzy and they're passing out and all kinds of problems. Same with small fiber neuropathy in the corner there. I think 0.8% is really kind of an underestimation. It's probably more like 10+% of patients with Sjögren's have small fiber neuropathy, but it's just not measured here by the ESSDAI. But we move on. All right, ultrasound. People are often curious about ultrasound. A lot of folks use ultrasound in lieu of a minor salivary gland biopsy for diagnosis, especially when the SSA is negative, SSB negative. So ultrasound can be helpful. It is useful to have the radiologist report an OMERAC score. We have asked this of our radiologists over the past few years, and now they have trained themselves to do this and do this routinely. Is quite helpful. Essentially looking at the parenchyma. You can see the parenchyma here has the kind of some of these kind of black circles in it. These are anechoic areas, and this is what we're looking for in Sjögren's. This is kind of like what we see. And so a score of 0 is a normal parenchyma. Everything looks smooth and homogeneous. A score of 1 is there's some inhomogeneity, but there's no anechoic areas. There's none of these pock marks. A score of 2 is you have some of these, and a score of 3 is that these are kind of widespread and diffuse. So 2 and 3 is associated. It can be helpful for the diagnosis of Sjögren's. For instance, I saw someone just yesterday who's had like, I don't know, over 10 years of dryness, dry eye, dry mouth, SSA is negative. She's convinced she has Sjögren's. I had her go for an ultrasound and the score was 0. Hard for me to imagine that her dryness after so long is from Sjögren's, if there's really no kind of changes in the anatomy that we typically see in Sjögren's if she's really that severely dry. So I don't know that a lip biopsy would be all that helpful in that patient. But on the flip side, it could be. I mean, I have seen patients who have a normal ultrasound and do have a positive lip biopsy. Of course, for that patient, having dryness for that long, I wouldn't expect it. But certainly people who have symptoms for just like a year or two, having a negative ultrasound in my mind does not rule out Sjögren's. Maybe just hasn't had enough time to have significant changes. I have at least 10 or 20 patients with 0 and 1 changes on ultrasound, but a lip biopsy that's positive. Round 2, emerging therapies for Sjögren's disease. All right, more questions. Here we go. Which statement is true regarding symptom-based management of Sjögren's disease in clinical practice? A, symptom-directed therapies may improve dryness, but may have limited impact on other systemic complaints. B, persistent symptoms are more often related to comorbid conditions than to ongoing Sjögren's disease activity. And C, optimizing topical and supportive measures leads to sustained improvement across most symptom domains.
And polling is open. Please vote. We'll give a few more seconds for incoming replies. Excellent, thank you. And we'll go ahead and close that poll and share the results.
Okay, well, we got a mix here. Symptom-directed therapies may improve dryness, but may have limited impact on other systemic complaints. That's how I see it there. And number 4, which statement is true regarding emerging therapies for Sjögren's disease? A, quality of life benefits observed with emerging therapies are driven by improvement of psychosymptoms. B, persistent symptoms are more often related to comorbid conditions than to ongoing Sjögren's disease activity. Or C, improvements in objective disease activity translate into parallel improvements in quality of life.
And polling is open. Please vote. We'll give a few more seconds for incoming replies. And we'll go ahead and close that poll and share.
Okay. Improvements in objective disease activity translate into parallel improvements in quality of life. Okay, a lot of you were with me there. Let's move on. So now we have the EULAR recommendations for Sjögren's disease management. I like this paper. There's a lot of nice figures in there that are useful. And they mentioned that patients with Sjögren's should be managed using a multidisciplinary approach. That's certainly very true. These patients have lots of problems with lots of different organ systems involved. And so it's helpful to have different specialists assist in caring for the patient. And in blue here, first therapeutic approach for dryness is symptomatic relief, artificial tears, ocular gels and ointments, saliva production stimulators, artificial saliva. Severe ocular dryness can be managed with immunosuppressive drops or autologous serum eye drops. I wonder how many of you have patients who have serum eye drops made from their own serum. And analgesics, pain management, agents for musculoskeletal pain. And then in black here, we see systemic therapies may be considered for treatment of active systemic disease. Steroids should be kept at the minimum, which is pretty common for us in our diseases. Immunosuppressive agents, there's no evidence to support one over the other. That may have been true in 2020. There might be some evidence to suggest one might be better than another, but overall, I think that's still pretty true. And then B-cell targeted therapies can be considered for severe refractory systemic disease. We know that the B cells play a huge role in Sjögren's with antibodies, and et cetera, and lymphocyte infiltration in different tissues. So it makes sense that B-cell targeted therapies should be helpful for Sjögren's. All right, myth 4, symptom management is the only approach for Sjögren's disease. Okay, this slide is kind of showing how things perhaps were in the past or have been, using biologics early on is rarely done, at least back here in 2017. But perhaps that's going to change. Let's look at other therapies for Sjögren's. Hydroxychloroquine is prescribed for nearly 50% of patients. Certainly offer it for the majority of my patients. Even though the Johr trial, many of you may know, Johr trial, it's a randomized controlled trial. They showed no improvement in Sjögren's symptoms. Their endpoint was a little funny. They looked at a 30% increase from week 0 to 24 in 2 of 3 scores of dryness, pain, and fatigue. And they looked at a really breadth of different Sjögren's patients. Part of the literature that's complicated is the patients of Sjögren's in some of these studies really, really broad. There was like a sub-study looking at just patients who had like high symptom burden, and they seem to improve from hydroxychloroquine. So maybe some patients that improve, others that don't. And here we just looked at such a large group of patients that it didn't come out in the wash here. And then they mentioned the repurposed trial in 2020, which, as far as I know, is the first randomized controlled trial in Sjögren's to have a positive outcome. Found a significant clinical response when hydroxychloroquine was combined with leflunomide, which is why I say, what I said in the previous slide, that there's, no data to show why one medication may be better than other. Well, you could argue here leflunomide along with hydroxychloroquine, it showed some improvement. So perhaps you might add leflunomide to hydroxychloroquine if hydroxychloroquine alone is not working. You could argue that here based on this data. And then new disease modifying agents are still needed, which is very true. Again, more questions. Here we go. Post-test number 2. A 46-year-old woman with Sjögren's disease presents with a history of dry eye and dry mouth, despite regular use of artificial tears. Over the past 3 months, she's also noted swelling of the parotid glands, fatigue, and arthralgias. What can you tell the patient to explain her symptoms? A, symptom-directed therapies may improve dryness, but often do not address systemic disease burdens. B, supportive care resolves both glandular and extraglandular symptoms when used consistently. C, the fatigue and arthralgias may indicate associated autoimmune condition. And D, systemic symptoms will dissipate once glandular dryness is stabilized.
And polling is open. Please vote. We'll give a few more seconds for incoming replies. And it looks like oh, yeah. All right. We'll go ahead and close that poll and share.
Okay, looks like you know the answer. Very good. Topical supportive therapies can relieve sicca symptoms. Many patients continue to experience fatigue, pain, systemic manifestations significantly affect quality of life, highlights the unmet treatment need beyond dryness-focused management. Broader therapeutic strategies are needed to address systemic disease burden. So true. Okay. Myth 5, disease-modifying therapies for Sjögren's have failed in clinical trials. Well, we're going to talk about those in red here. You can see in the upper left corner, telitacicept and ianalumab, both affecting the B cell, affecting BAFF and APRIL. In the middle here, dazodalibep, affecting the interaction between B cells and T cells. At the bottom here, deucravacitinib, a JAK inhibitor inhibiting TYK2. And then in the bottom right, the FcRn inhibitor nipocalimab, which affects IgG recycling, lowering IgG levels. So we're going to look at these trials, starting with Neptunus 1 and 2. So this is looking at ianalumab, which is essentially blocking the BAFF receptor. So we're all, I think most of us are familiar with belimumab, which blocks BAFF, and rituximab, which winds up destroying B cells. But interestingly, ianalumab attacks the BAFF receptor, which blocks BAFF and winds up killing the B cells. So I think of it as like kind of a combination of these two drugs. Pretty interesting, at least in theory. So this is an international double-blind, placebo-controlled, randomized phase 3 trials, Neptunus 1 and 2, where they took patients with Sjögren's who had positive SSA, who had some salivary flow, and who had an ESSDAI score. And remember, the ESSDAI is systemic involvement of greater than or equal to 5 across 8 domains. So you had to have at least moderate active disease and a positive SSA to be into this trial. You could have concurrent stable doses of hydroxychloroquine, methotrexate, et cetera. And what they did was they took the patients and looked at them. They gave them ianalumab, 300 milligrams subcutaneous monthly for 52 weeks, or placebo monthly for 52 weeks. And that was Neptunus 1. And Neptunus 2, they just had more patients, and they had a third arm, which was ianalumab every 3 months. It was kind of a third arm. And then they looked at them, followed them up at weeks 48 and 52. The primary endpoint was a change in the ESSDAI score at week 48. And then there was a bunch of other endpoints there, as you see, including physician global, patient global, and other safety, et cetera. And what we see here in these images in Neptunus 1, you can see that ianalumab versus placebo both had a significant improvement in ESSDAI score. Remember, we want to see the ESSDAI change at least 3. Here you could see placebo improved by 5.1, and then ianalumab improved by 6.4. And there's a significant difference between the least square mean of the two. And then you can see here in Neptunus 2 on the right side, a significant difference between ianalumab monthly and placebo. They also want to point out here is that in both trials, quality of life, according to patient and physician global assessments in Neptunus 1 versus placebo, is also significantly improved. So what is this telling us? That means that not only did we have an improvement in this obscure score that most of you may not be testing and measuring, but also the patient global, the patients felt better, and the physician global, the physicians thought the patients were doing better. So there was improvement from the patient standpoint and the physician standpoint on this drug. And in terms of safety, if we look at serious adverse events, ianalumab, like 3.6% versus placebo, 8.7%. In Neptunus 1, 9.5% compared to 10.7%. So really overall, seems like this seems to be a safe medication. If you look at serious infections, 2.2% in ianalumab versus placebo, 0.7%. In Neptunus 2, which had more patients, 3% versus 4%, 4.7% in placebo. So it really seems to be a safe drug. Okay, now we're going to look at the other kind of B-cell directed therapy, telitacicept. This affects BAFF or BLyS, but also affects APRIL, which is a similar type molecule, also affecting B cells in patients with primary Sjögren's, a multi-center, double-blind, placebo-controlled, randomized phase 3 trial. Again, they looked at patients who met the classification criteria we reviewed, who had positive SSA, think a lot of these trials really want to make sure that patients do better, so they got the people who are kind of had a very active immune system. So having positive SSA patients was a plus. And an ESSDAI score of greater than 5, so you had to have at least moderate disease activity. And so they had them in 3 different groups: the telitacicept subcutaneous weekly at 80 milligrams, so low dose in red, higher dose in blue, 160 milligrams, and then placebo. And they followed them up at weeks 24 and 48. So the primary endpoint was a change in ESSDAI score at week 24, and they had a bunch of different secondary endpoints, which you see listed here. Telitacicept significantly improved ESSDAI scores at week 24 in both treatment arms versus placebo. So you could see, again, red is the low dose, blue is the higher dose. And you could see the change in ESSDAI score up here between placebo. Again, you want a change of ESSDAI of at least 3 to be clinically significant. The folks in placebo here, they did not respond. People here did not respond to placebo in this trial, but they certainly responded here to the telitacicept. And you can see the same thing over here. And what you see here is the placebo folks were offered drug, and the dotted line is after they got the drug at the different doses, what happened over time. You see that they kind of catch up with the 2 groups that were treated. So certainly looks like telitacicept is doing something there in terms of the ESSDAI up here. And then the bottom, this is looking at the esprit. So symptoms were improving significantly here, and symptoms were improving significantly in the treatment group. So looks pretty nice. Safety, most adverse events were mild to moderate in severity, and no deaths were reported. Now let's look at dazodalibep. This is a CD40 ligand antagonist, so it kind of inhibits the interaction between B cells and T cells. So they can't interact properly, and that's how it works. This is an international double-blind placebo-controlled randomized phase 2 trial. I like this trial. What they did is they looked at 2 different populations. And so population 1 was patients who had an ESSDAI score of greater than 5. That's kind of like what we're looking at with all these other trials today. But then population 2 was those who had an ESSDAI of less than 5. So I told you the average ESSDAI score in my population here is like 2 point something. So a lot of the patients don't qualify for these trials because they just don't have a high enough ESSDAI. Well, population 2, pretty much all comers. They just had to have symptoms, which is pretty much like 90% of my patients have an esprit that's elevated, but maybe an ESSDAI that's not so high. So this would like literally apply to like 90+% of our patients here, so they could enter this trial if they wanted to. So in population 1 or 2 was the same. They gave patients dazodalibep, 1,500 milligrams IV, essentially like every 2 weeks at first and then monthly versus a similar placebo. And then halfway through, they switched. So those who were on dazodalibep got placebo, and those who were placebo got dazodalibep. And then they looked at the data. And the primary endpoint was a change in the ESSDAI score for those who had a high ESSDAI, or a change in the esprit, again, the symptoms, in those who had lots of symptoms. So I like the study, pretty nice. And so what they saw was significant improvement on the left here, population 1. Again, these are people with who had at least moderate systemic involvement. You could see the improvement in ESSDAI score. The placebo effect was pretty significant. It was around 4. So the placebo group seemed to improve quite a bit, but the dazodalibep group improved even more. And the difference between the 2 was statistically significant. So the dazodalibep group improved by 6 points. It's quite a bit. That's a lot. Again, 0 to 5 is low disease activity. 5 to 13 is moderate, and they improved by 6. It's a lot. Very good. And then on the right side, you see the population that has lots of symptom burden, but don't have a lot of systemic involvement. And you could see, again, the change in esprit of 1 or more is clinically significant. You can see the gray line there. They're not improving by 1. So people who got placebo did not have a significant improvement in their symptoms. And then population 2, dazodalibep, improved by minus 1.8. So pretty a significant improvement in symptoms, and statistically significant compared to placebo as well. Next, we look at nipocalimab. So this is an FcRn antagonist. Essentially, this is going to lead to lower IgG immunoglobulin in patients, including immunoglobulin that's causing trouble. So it's how it's going to help. in patients with moderate to severe primary Sjögren's disease, multicenter, double-blind, placebo-controlled, randomized phase 2 trial. Again, this one is looking at patients with a high ESSDAI, but they have an even higher bar, an ESSDAI score of 6 or more, as opposed to 5 or more, had to be positive SSA. And what they measured was not just the normal ESSDAI, but a clin ESSDAI. Essentially, this gets rid of the biologic domain. If you remember, biologic domain, you can get points for hypocomplementemia, hypergammaglobulinemia. And it wouldn't make sense to measure that here because we know that nipocalimab is going to lower IgG levels. So if you get points in your ESSDAI for hypergammaglobulinemia, this is going to show that that improves every time just because of the mechanism of action, kind of like tocilizumab lowering CRP. So they kind of removed that from the scoring system to make the data kind of make more sense and be cleaner. So you need a change in the clin ESSDAI at week 24, and they had 5 milligrams. So red is the lower dose, blue 15 milligrams per kilo is a higher dose, and then placebo. And you see the secondary endpoints there were ESPRI and others. And what you see here is with the higher dose group, on the left, a change in ESSDAI scores over time. The nipocalimab in blue, the higher dose group, has a statistically significant improvement in ESSDAI compared to the placebo group. And so we see that nipocalimab may be helpful according to the Dahlia study. So we'll see if we see this drug. Very interesting. And this shows you some of the different domains, like which domains were improved the most by nipocalimab. So maybe these are the people for whom the drug may be most helpful. Patients with constitutional, glandular, articular, cutaneous, hematological involvement. So it might be that these patients are the ones most likely to improve with this drug. Dahlia's was well tolerated. There's no deaths or opportunistic infections. Most common adverse events were hypersensitivity reactions, COVID-19 infection, and headache. I think much of this trial was done during the pandemic. Next we have deucravacitinib. So this is something medication is a JAK inhibitor blocking TYK2, which leads to diminished interferon. So this is modulation of interferon inflammatory pathways. In a phase 2 clinical trial for lupus, deucravacitinib demonstrated significant reduction in interferon gene expression. Results suggested deucravacitinib could be effective for managing Sjögren's. The pathogenesis of Sjögren's and lupus both tied to interferon pathways. And so there's phase 3 trials ongoing. And you can see here that there's trials that are ongoing here in development, recruiting. We're recruiting for folks for at least one trial and hopefully a second one soon. And how can these newer therapies be used in practice? We're going to see. It's going to be a very interesting time. Talking about this a lot with my patients. They're very interested in this. They're interested in trying to feel better and trying to make their disease better. It's not always so easy. It does take a village. You can see here, interdisciplinary management of Sjögren's disease really takes a lot of different specialists. I send my patients to lots of different providers to help with their various manifestations, and hopefully all together we make a difference for our patients. And here we are with post-test number 3. During her appointment, a 49-year-old woman with Sjögren's disease shares that she recently heard about ianalumab from an advocacy group. Based on emerging data, which of the following best summarizes what she can expect? Improvement in glandular symptoms only, improvement in extraglandular symptoms only, improvement in ESSDAI score, improvement in physician global and patient global scores, but no change in ESSDAI score.
And polling is open. Please vote. We have a few more seconds for incoming replies. Thank you. And we'll close that poll and share.
Okay, great. Exactly. Improvement in ESSDAI score. Okay. Yep. In phase 3 Neptunus trial, ianalumab showed improvement in ESSDAI, physician global, patient global. Key clinical takeaways. Disease burden extends well beyond sicca symptoms. Sjögren's is so much more than dryness. fatigue, chronic pain, cognitive dysfunction, psychological distress, significantly affecting patients' quality of life, daily functioning. These patients really suffer. Current management strategies for Sjögren's disease are largely symptom-directed. However, emerging targeted therapies may reshape this landscape. Very exciting time. Early recognition of patient education of Sjögren's disease are critical. Helps patients understand the systemic nature of the disease and rationale for multidisciplinary care. And then last, do you plan to make any changes in your clinical practice based on what you learned in today's program?
And polling is open. Please vote. We'll give a few more seconds here. Thank you. And we'll close that poll.
Oh, good. I'm glad. Okay. Well, please take a moment to enter one key change you plan to make in your clinical practice based on this education. You can scan the QR code, and I'm happy to answer any questions that you may have. I don't even know how many of you there are. I really like giving presentations in person. It's always strange to do it virtually. I don't know if I'm talking to 5 people or 5,000. It is Texas, so maybe it's 5,000. I don't know.
Yes. Thank you so much, Dr. Johr. We're now taking any questions that you may have for Dr. Johr. Please use the Q&A function in Zoom to submit them. And while you do so, there are links in the chat panel. We'll also put in a few QR codes momentarily. One will lead to the downloadable slide deck from today's presentation, and the other will lead to the program evaluation link to complete and claim your credit for attending. You will need to log into or create a DCE account, and we would encourage you to claim your credit within 30 days, as credit for today's program will expire after this time frame. So we do have one final opportunity for any questions. I do see a few that have come in, Dr. Johr.
Yeah, please.
I will go ahead and read those out to you. The first is, how should fatigue and cognitive symptoms be interpreted when SICA findings are stable?
So I don't think of these things as necessarily going hand in hand. A lot of patients can have, any number of different symptoms and manifestations changing at different times. It's like somebody who has spondyloarthritis and IBD, their gut might be stable, but their joints might get worse, or vice versa. They don't necessarily have to go together. So, if someone's SICA, regardless of someone's SICA manifestations, if their fatigue is worse, I'm going to look for treatable causes and try to address that. And then I may try addressing it in any number of ways. To talk about fatigue and Sjögren's, I could probably spend an entire hour talking about that, so it's difficult. But definitely look at their thyroid. A lot of patients with Sjögren's have concurrent autoimmune thyroid disease. So I check a TSH in my patients yearly who don't have known thyroid disease. Look at their hemoglobin. I look at their ferritin a lot of times. Look at their B12. A lot of patients have concurrent B12 deficiency due to like atrophic gastritis and other things. That's a long answer. I hope I answered that well enough for now.
Great. I do see a comment in the chat asking if the slides will be shared after the meeting. There is a link in the chat panel to lead you to the slide deck. You will need to log into or create a DCE account in order to access those. The next question, Dr. Johr, is what metrics best reflect disease control?
I'm sorry, read that again, please.
Excuse me. What metrics best reflect disease control?
Oh, I'm not sure how to answer that question beyond stating what we kind of reviewed today. I mean, we here measure patients' ESSDAI, so certainly having an improvement in ESSDAI reflects disease improvement and control. If someone's ESSDAI is low and they have low disease activity. But again, I also pointed out that that doesn't cover everything. It doesn't cover symptoms. It doesn't cover some of the manifestations that are just not reflected in the ESSDAI. My patients who have very severe autonomic dysfunction, for instance, their ESSDAI might be 0, but their disease is very poorly controlled and out of control. They're passing out. They're having all kinds of issues. So I'd say it's a very heterogeneous disease. It totally depends on the patient. Really depends on the patient. But we look at symptoms, we look at organ manifestations, and And whatever that patient happens to have, I think the answer varies based on that.
Okay. And the last question that I see now is this could maybe kind of fold into what you just mentioned. It says, how do ESPRI and ESDI complement each other in assessing disease burden?
Yeah, I think I think the ESDI is looking at the systemic nature of the disease, and the ESPRI is looking at some of the patient's symptoms that may or may not reflect the systemic disease. And so I think that's why we have both of those things. A lot of patients may have a low ESDI but still feel terrible, and we want to record that. And so I think that's why we have both of these. And I challenge us all to come up with something better. It's not ideal. There's certainly a lot of patients who are unhappy with this and feel like we can do better, and I bet we can, and I bet we will, but that's what we have for now. It's what we've been using the literature for a while, and it is certainly helpful to measure some of these different activities. I think it's really useful to look at the ESDI because it does kind of force you to go over all the different manifestations of Sjögren's. And when I started kind of using ESDI in my regular clinical practice through EPIC, or EMR, I started asking different questions and asking certain questions more regularly because I was looking for the answers to the ESDI and finding that patients really are having a lot of these symptoms and a lot of these problems that I may not have been asking about before.
You have been listening to CME on ReachMD. This activity is provided by Clinical Care Options, LLC, doing business as DeSera Clinical Education and in partnership with Smart Patients. To receive your free CME credit or to download this activity, go to reachmd.com. Thank you for listening.